So tonight, everyone, we don't really have that much of a packed agenda. We do have our Medicare for All activist meeting tomorrow night. And we would really like it if everyone who is interested in participating in our advocacy work would attend. And that could be found on our website. And you can sign up for that. The meeting time is from 7 until 8. And we have combined all of our committees into one meeting a month so that it isn't too much for myself and Sivan and Rana and now Josh, because we were going to meetings every single night. So the only committee that has not been brought into this under this one umbrella is the electoral committee because of some of the nature of the information that is shared in those meetings. So we would really love to have as many voices as possible in the Medicare for All activist meeting. And again, you could find that information on our website and you can go and sign up for our meeting at 7 o'clock for every Wednesday, every second Wednesday of the month, I believe it is. And also, of course, we are still a baby organization and any donations are welcome because it is expensive to keep the lights on, so to speak. We are wondering if we can look for 501c3 so that we can go for some grants possibly to be able to put out more information and do more door knocking and leave more information behind, because right now we do not have the funds to do that, which is very important to educate more people. Currently, we are taking advantage of the free printing services that Yale has to offer. So sometimes they aren't always the evil empire, as I refer to them. Sometimes we do get some good things out of there. They're not always evil. And tonight we have an amazing speaker, Professor Leonard Rodberg. I have always loved everything that Professor Rodberg has spoken at, that I've heard, that I've attended. And I was so very honored when he said he would, speak tonight. Professor Rodberg holds a PhD in physics from MIT. Dr. Rodberg retired in 2017 as professor and chair of the Urban Studies Department at Queens College, City University of New York. He began his activities in healthcare in 1974 when he led the development of Dellum's Health Service Act. He was one of the founders of Physicians for National Health Program, yay, and is now on the board of the New York Metro chapter, is research director of the chapter, and is on the board of Campaign for New York Health. Most recently has been involved in the fight to preserve Medicare as a principal source of health coverage for retirees of the city of New York. Without further ado, Professor Rodberg.
Great. Thank you. Thank you very much. Pleasure to be here and talk to you. I've sent Holly a PDF. I'm going to use slides. PNHP is known for its slide presentations, and I've been doing them for many years. So that's what you're going to see and hear, those of you that will be able to watch. I've sent her a PDF of the presentation, which I hope she'll circulate after we're done, and you can go back over it because I'm going to be presenting a lot of stuff, and it'll probably be useful to go back and look at it later. And I welcome comments and questions here, of course, but also afterwards if you want to engage in debate or controversy or just have a discussion. So let me share my screen so you can see what we're about, and we'll get started. Okay, so that's just who I am. Believe it or not, most Americans agree with us that everyone should have access to affordable health care, although we seem a good ways from getting to the universal coverage that we all long for. In fact, the current situation, I'm sure all of you know, is that there are still about 10% of our population that has no insurance. And in New York City, in New York State, it's 5% because we have expanded our Medicaid program substantially. But there's still 1 million who are uninsured, according to federal statistics, which really means uninsured for an entire year. There are, of course, many more uninsured as they move from one job to another. And there are many more who are underinsured who discover that when they thought they were covered, they actually weren't. And costs are continuing to rise. This is the Kaiser data going back to 1999, showing basically a tripling in the cost of healthcare, up over $20,000 now for a family policy, and much greater than the rise in people's wages or general inflation. The orange and yellow line is the insurance premiums. This is employer-based insurance, which most people who are not retired get their coverage from when they have coverage. Substantially greater rise in the cost of healthcare than in wages and general inflation, the blue and black lines. And the out-of-pocket costs continue to rise. This is in just 10 years, a tripling of the deductible, what you have to spend out of pocket before you get any coverage at all. So, and uninsured continues to rise. This is, this is the way unemployment was rising. Then the Obamacare, Affordable Care Act came in and reduced it substantially, really, almost 10 million nationally. And then COVID drove it up again. I haven't followed the newer figures. This figure was actually prepared by David Himmelstein and Steffi Warhandler a year ago. And we all know it doesn't have to be this way. This is my favorite graph because it shows how backwards this country is. These are the major industrial capitalist countries. This is OECD data, includes everything from Sweden, Germany, France, Britain to Japan. And they're all around 10% of their gross domestic product. And there's the United States of close to 20 and rising. And many of them, I did a paper with a student a few years ago, and a third of all countries have basically no cost sharing, including Canada. And yet their costs, Americans can't believe that if you don't have skin in the game, spending will go out of control, but it doesn't. So what do they know? What are they doing right that we're not? The answer is that we treat healthcare as a marketplace, and I'm going to come back to that later. But the basic difference is they understand that government, that it's not a market, that people can't bargain for over what the price will be, can't even know what the price will be until you've actually gone through whatever treatment you need. That government has to oversee, regulate, and sometimes fund healthcare. And we haven't learned that lesson yet, although all of us in the single payer movement understand it very well. Here's further support for the ability of government to control the cost of healthcare while providing widespread coverage. The orange line is private insurance costs average per person over the last 10 years, and the darker lower lines are Medicare and Medicaid government programs. They set their reimbursement rates, and private insurance cannot do that. It has to bargain with increasingly powerful hospital systems and medical groupings. So the message, whether it's internationally or national or in the US, is clear that private costs of health, private healthcare is inflationary and public is not. Yet private coverage dominates in this country. There are three kinds of it today. We have the employer-based coverage, which covers about half the population. We have Medicaid managed care every place but in Connecticut, which I'll refer to a little bit later. And increasingly, Medicare itself is being privatized. And that's what I'll focus on here in order really to clarify the role of the private sector in healthcare finance. So I'm going to do this with children's, this treat healthcare as child's play. I went to my grandson's toy box and pulled out some blocks and arranged them on an infant blanket, if you would. And so here's the source of funds, the payer. Then there's a supplemental payer for that, if you're lucky enough to have that, which will cover what the main payer doesn't cover. Then there's the primary care provision, the physicians and other primary care practitioners, nurse practitioners, and so on. And then there's specialists in hospitals, and then there's the patients. So this is the terrain on which healthcare finance operates. So here's Medicare, the payer. I mean, ultimately, of course, is the taxpayer, but the payer in this case is the Center for Medicare and Medicaid Services. It uses fee-for-service. What happens is the patients see their doctor, the doctors file a claim with Medicare, and Medicare pays 80% of the bill for physicians and some more complicated percentage of the bill for hospitals. If the patients have supplemental coverage, Medicare forwards the claim to the secondary or Medigap carrier, and they pay the rest of the bill. Or now in New York, they pay the rest of the bill except for a copay, which the patients have to pay. Consumers Union looked at insurance. They frequently have reports on insurance, and they refer to the Medigap or supplemental coverage as a bookkeeping operation. There's no decision-making made. Insurance companies make a profit out of it, but they and treat it as a risk-based provision of insurance, but there's no decision-making at the secondary level. The decision-making is made by Medicare, and Medicare covers what doctors prescribe. So that's our current form of the best current form of public health coverage. It's our model for what we want, our vision for healthcare for all. But it's quite deficient. It doesn't cover our teeth, our ears, or our eyes. Doesn't have long-term care either. It has costly deductibles and copays. It has no limit on out-of-pocket expenses. You can get Medigap plans, but they cost more that will limit your exposure. But Medicare itself has no limit. The result is that the average Medicare recipient spends more than $6,000 a year on healthcare. And the result is that it's subject to tax from the private sector and to privatization, to intrusion into this public system of the private sector. And here's my definition of privatization. It's not an objective dictionary. You won't find this definition in the dictionary, but it both defines it and it describes what it does. Privatization in healthcare occurs when access to care is controlled by a private entity, which can make money by limiting access to care. We as another way of saying the special nature, if you like, of our healthcare system is we have set up private insurance with what economists call a perverse incentive. The less service they provide, the more profit they make. They make money by limiting access to care, as I say here. The first phase of that is the Medicare Advantage program. It actually began, a form of it actually began in the 80s. Once Medicare was created, there was continuing pressure from the Congress to allow private insurance companies to get into the game and get some of that federal money. It was tried in the 90s under Clinton. It was called Medicare Choice Plus. Insurance companies couldn't make enough money out of it because people believed the myth about the private sector, which was that it was more efficient and therefore Medicare only paid 95% of what Medicare itself was spending. and the insurers couldn't make money and they were bailing out of the system. So in 2003, under George W. Bush, the Congress redesigned the program and relabeled it in an advertising form built into the legislation. They called it Medicare Advantage. Of course, New York City these days, with the fight we're having, it's Medicare Disadvantage. I will show you why. So how does it work? Well, it works by the individual Medicare recipients choosing to sign up for a Medicare Advantage plan rather than for public traditional Medicare. Those copays, the deductibles, the need to pay for a Medigap plan, the need to pay for a drug plan. All of those bear on, particularly on low and middle income retirees who living on fixed incomes. And so they choose to sign up with the Medicare Advantage plan, which often has no premium, zero premium. And so they sign up with the insurer. Medicare then sends a monthly capitation payment to the insurer, to the insurance company, for each member, each person who is signed up to the insurance company. So they have fixed amount of money to spend on healthcare, and they try to keep as much of that as they can. So what happens now is when the patients see a doctor, the doctor has to go to the insurance company to get approval for whatever treatment or test, even for a CAT scan or an MRI. They claim to manage care, but this is the extent of how they manage care. They approve or often disapprove treatments or tests recommended by physicians or hospitals. The service is covered but not allowed because, in their view, it doesn't merit the service. Traditional Medicare, basic public Medicare, does not require prior authorization for any medical procedure. It does require authorization for very, very expensive medications, but very, very few of them. But doctors, there's no, you go back to what I said before about Medicare, if the doctor submits a bill, Medicare pays it. Or as I say here, what the doctor orders gets done. If the insurer approves, then the doctor gets paid, or the hospital gets paid, and there are often copays. There are a lot of copays. So it not only costs the patient money, but facing the copays, patients will think twice before going initially to the doctor. And that's another way in which the insurer saves money, not only by denying care when the doctor requests approval, but also by discouraging the potential patient from seeking the care in the first place. I mean, when there's somewhere between a $50 and $150 copay, when you go to an emergency room, people wait to see if they can survive without having to go and spend that $50 or $150 out of pocket. What about Medigap? What about the other 20%? There is none in Medicare Advantage. The total amount of money available to the insurer is what Medicare gives it, which is 80% of the Medicare rate of the total cost, plus some subsidy. Because of the pressure from Congress and from private sector, initially under Bush, the subsidy was as much as 15% above what Medicare pays directly, traditional Medicare pays. It's now about 4% above regular payment. So there's less money available to take care of people under Medicare Advantage. First, because there's only the 80%, and then the overhead of private insurers is quite substantial, over 15%. And so from the combination of the cost of the staff they maintain to get the requests from doctors and deny them or sometimes approve them, but also marketing, advertising costs, the multi-million dollar salaries, even for nonprofit insurers like we have in New York. Emblem Health, the CEO makes $5 million a year. And if it's a for-profit company like Anthem or Empire Blue Cross in New York, is their profits, which are about 5% of the revenue. It's very profitable because their expenses are not, most of the money they get is passed through to medical providers. So it's quite a profitable industry. Maybe the next slide will show you. Medicare Advantage today is the most lucrative form of private insurance because seniors are sicker than the average in the population that's covered by private insurance. And this is the overhead. This is not the profit. This is the total, non-medical expense. You can see at the bottom basically is what's called the medical loss ratio, which is about 86% of revenue is spent on medical care. When Medicare Advantage patients get sick, they as soon as they can, they go back to Medicare. They flee back. This is just a cover sheet. The left side is just a cover sheet from 2012 of what this refers to as biased disenrollment. That is, the people who disenroll from Medicare Advantage and go back to the fee-for-service Medicare are sicker on the average than the average person. They hit when you get sick on Medicare Advantage, you experience the limited network of physicians who are willing to take it, and the hospitals too. Some hospitals won't take Medicare Advantage because of the prior authorization requirements and the low fees they pay. And the copays and all lead people to go back to Medicare. And just a study just a few months ago on the last year of life that again, there were biased disenrollments of people from Medicare going back, from Medicare Advantage going back to Medicare because of the burdens in trying to get care that you face when you're in a Medicare Advantage program. It's that perverse incentive. You're getting your coverage paid for by somebody who doesn't want to pay it, namely a for-profit or quasi-nonprofit corporation. So the bottom line is that Medicare Advantage costs the government more than public Medicare. It gives patients less care than public Medicare, but nevertheless, nearly 1/2 of all Medicare recipients are now in Medicare Advantage because as long as they're healthy, it costs them less. People expect this year or next that more Medicare recipients will be in Medicare Advantage than in traditional public Medicare. And why do they use it? Most people don't use much healthcare. That's why the surveys say most people like their Medicare Advantage plan. You can't believe the surveys for this question, for this matter. This is what referred to as the 80-20 rule, that 80% of the spending in any one year is on 20% of the people who happen to be sick that year. Most people in most years are not sick and they don't use the insurance very much. And if a survey asks them, are they satisfied with the insurance? Their answer is yes, because they haven't used it. Or if they used it, it was for very minor things and they don't even remember what their experience may have been. So that's the kind of privatization we already have. Now we come to phase 2, the latest thing that's happening. CMS keeps trying to push the private sector into its public program. That's created a new model for those of us who aren't in Medicare Advantage. I'm in Medicare traditional, and it was called direct contracting, but PNHP has led a fight against it over the last year with a lot of noise and visits to the directors of CMS and letters from the Congress to the Secretary of HHS, and they got a bad name, so they created a new name, and they're now calling it ACO REACH. ACO is Accountable Care Organization, and I don't remember that what REACH stands for. We may find out here, but I don't think so. There's no change, no significant change in the plan. The plan is now in its test phase. There are, I don't know, a few 100,000 people, patients being who are in this plan, although they don't know it. Many of them will not know it. But CMS has big plans for it. This is from the director of the Center for Innovation at CMS. CMS is committed to the shared goal of moving away from fee-for-service. Our goal of moving 100% of traditional Medicare beneficiaries into accountable care relationships by 2030. So they want all the rest of us to be in this program by the end of this decade, all those of us who are in Medicare. So how does it work? Now, this is, at least by name, not an insurer inserted between Medicare, the funder, and physicians and hospitals. It's called a DCE, a direct contracting entity. And the reason they use the term entity, it can be a variety, any private sector organization that can oversee the funding of healthcare. That's basically the definition. There are now, there were 53, I think there are now 100 in this test across the country in this test phase. A number of them are insurance companies. Venture capital is seeing this as a new field to make profits out of. And there are some medical group practices in here that are placed between Medicare and doctors and their patients. And how does it work? First of all, what happens is primary care, remember under Medicare Advantage, individuals signed up with the insurer. The individuals don't do anything in this model. Mainly the primary care practitioners sign up with the DCE, and instead of getting their payments from Medicare on a fee-for-service basis, they get a monthly per person payment. They get a steady payment. So the advantage to them is that they have a steady, assured income once for each of their Medicare, the Medicare patients. Why the focus on primary care? Well, CMS says that advancing primary care is a means to better manage healthcare overall. What they mean is better control the cost. Primary care itself accounts for only somewhere between 3 and 5% of healthcare spending, but it's where all the decisions on what medical treatments to get, which are where the real costs are, and particularly what hospitalizations are going to be required. So it's the linchpin where the rest of medical and hospital spending can be controlled. So the way it works is the PCP, the primary care practice, signs up with one of these DCEs, one of these corporations, to get its payment for Medicare recipients on a capitated per month basis. And Medicare, the DCE reports to Medicare that it has signed up this particular practice. Medicare goes to its computer files and looks at what Medicare recipients have been using that PCP as their source of primary care over the previous 2 years. And those patients are considered to be, quote, aligned, which means that they will be credited to the DCE, and the DCE will then get a capitated payment each month for each of those patients. Some DCEs will handle just the primary care, and the specialists will be completely independent, but some will be under the umbrella and will be paid also by the DCE. So there are these really two models that are being, I think one's called global and one's called professional, which global means all medical care. So the DCE pays the PCP, the primary care practice, a monthly negotiated capitated payment, and it keeps the difference between what CMS pays it and what it pays to the PCPs and specialists and hospitals if they have come under its umbrella. Once a year, CMS compares its spending for all the services for the patients who have been identified with that DCE and compares that spending with what they would have spent, what CMS would have spent under normal traditional Medicare. If there are savings, those are split. 50% goes to Medicare and 50% goes to the DCE and its PCP. So they make money by saving money, by limiting care. This is what is called accountable care, or an accountable care organization. So there are financial incentives that are used to reduce spending on healthcare, because they basically are incentivizing primary care practices to act as shadow gatekeepers, limiting referrals to specialists or inpatient care so as to receive shared savings. They make money by delivering less care, and whatever care they don't offer, don't recommend or don't refer, of course, is invisible to CMS. So it looks like they're saving money and the patients are still getting the care they need. So why is this occurring? Well, there's some fundamental reasons in terms of politics, in terms of political power of the private sector in Washington. But what's their explanation for this? Their explanation for this program is that the fee-for-service system causes an overuse of services, and it's to blame for the high cost of US healthcare. And then that spending can be controlled through this kind of privatization and using what they call alternate payment models like capitation, as instead of paying fee-for-service, they'll pay a fixed amount once a month. But unfortunately, many of us believe in, many physicians, they practice evidence-based medicine, but CMS doesn't believe in practicing evidence-based policymaking because they're wrong. They're wrong. The fee-for-service system is not causing overuse of services. In fact, it's been known for a long time that our high cost is not the result of overuse of health services. This is a famous study from 2003, which says we actually have lower use of health services than other countries. Here's the physician visits per person. And these are, you can't read that, but these are some of those OECD countries, Canada, Britain, France, Germany, and so on. And the same with inpatient days in hospitals. The reason that we spend so much in this country is because of the prices are high, not because we are overusing services. And in fact, if I go back to this diagram and look at those countries, who uses fee-for-service, who uses capitation? Well, there are two countries that use capitation, Sweden and Great Britain in its National Health Service. Most of the rest, nearly all the rest, use fee-for-service. And yet they spend basically half what we spend. The reason is that they control the rates, the reimbursement rates, and there's no overuse. The prices are controlled, and there's no overuse of medical services. So why are our costs so high? It's our reliance on the market. It's the fact that we allow prices to be set by the providers of health services. We allow hospitals to set their own rates. And since at least major, they've merged, so now insurance companies have to have them in their networks and have to accept their fees. The result is that hospital fees today are more than 200% of Medicare rates. Rand's latest figure is nationally 274% of commercial insurance pays to hospitals compared to what Medicare pays. So we allow prices to be set by the providers of health services, and we don't regulate the private insurers. I mean, Switzerland and Netherlands have private insurers, but they regulate them. Same France and Germany, they have nonprofit insurers. They're totally regulated, and the prices are set by the government. No other country does this. We administer prices in Medicare, and its prices are lower and are more stable. A single payer program would use administered prices to control costs and can assure universal access without deductibles or copays, which, as I said, many many other countries already do. I'll just remind you here again that we already saw that public Medicare and Medicaid control costs better than private insurance. I mean, the notion that the private sector will control costs is a fantasy, but with this form of privatization, Medicare could in fact spend less. Certainly the DCEs and Medicare Advantage plans spend less. Their prices aren't lower, but they spend less. So the real way to control costs is to keep fee-for-service, adopt state level and national single payer, set physician and hospital prices through negotiations between government and organizations representing physicians and hospitals, which is what other countries do. So in fact, publicly funded single payer is the answer to both cost control and privatization. And in fact, you can look at this pressure for privatization as a way of avoiding Medicare for all, avoiding going the single payer route, which is the proper answer. Connecticut, thanks to Sheldon and Ellen here, has already done this. They deprivatized. They went back from a privatized Medicaid managed care plan to deprivatizing the program, so that the state pays in Medicaid, directly pays the providers, and the result was the cost went down while everybody else in the country were going up, and care became, we hope, more transparent and accountable. So here's the public route. It's the Medicare for all plans nationally, which I think you all know a lot about. Here's New York's plan. Gottfried and Rivera as the lead sponsors. I don't know if you all have heard that Gottfried is retiring. So we're going to need a new sponsor for this legislation. He's been in the legislature for 52 years, and he's retiring this year. And it covers everybody. One of the things it does is cover full-time workers, so that employers don't have to deal with two different types of workers, those that covered by New York Health and those that need private insurance. It provides very comprehensive benefits, and it costs less than we're now spending here in New York. Interestingly, the way the benefits are defined in the legislation is not in the right-hand column, is not by the type of service, but by the current plans. And it says anything covered by our children's health insurance program or Medicaid, our state Medicaid program or Medicare, or health benefit programs for state employees and state retirees is covered under the plan. But it also covers, long-term care because our Medicaid program covers long-term care. Again, there's three ways in which this saves money. First of all, its overhead is low. You don't have marketing, there's no $1 million salaries, and there's no private approvals. The legislation says that there's no more prior authorization required than is required by the Medicare program, the traditional Medicare program. And of course, there are no profits. Providers save money because they have simple billing systems. Canadian doctor makes a filing to the national Medicare program in Canada once a month. The simplification is extraordinary. And then drug costs will be negotiated and save money. Again, the US is the only country that doesn't control drug prices. Even when in Canada, drugs are not covered so far, still are not covered under their single payer healthcare plan, but they do regulate the prices. So their prices are substantially below what people in the US spend for drugs or Medicare spends for drugs. And this is the result of the analysis we've done of the cost of the New York Health Act. There are the three methods of saving through insurance administration savings, provider, hospital, and physician savings and reduced drug costs, a total saving. And then there's extra costs. There's covering everybody and eliminating cost sharing, so people will use the services more than they do now. They'll go to the ER more frequently if they need service and not have to pay a copay. We also include in the analysis increased, particularly physician fees, because Medicaid pays inadequately. And then there's the cost of long-term care that we cover, that is expanding it beyond what the Medicaid population today. And the net result is a savings, not a big saving, but it's billions of dollars. But it's a significant savings. And of course, heading into the future, you'll save more and more because of the ability of government programs to hold down costs far better than the private sector. And basically what you're doing, this is showing where the money comes from today, is from the federal government, from the state government, private foundations and so on, and then private insurance and out-of-pocket costs. And in New York, part of Medicaid costs are paid by the county government. So all of that is replaced by one new tax called the New York Health Tax, which is, it's a progressive tax. The first $25,000 is tax-free. And then it's a tax both on payroll and on non-payroll income. That is, people whose primary income is from investments pay as well as workers. And the economics, I say, works out. We've done a number of studies over the years about this. So single payer is good for everybody. You don't have to be employed, and we are very careful that the legislation covers residents, not citizens. So everybody, regardless of immigration status, is covered. And you've got greater equality and greater accountability. So the last thing I want to say is to urge you to join the fight against Medicare privatization. Even if you're not on it, eventually you will be. We hope, if it lasts. And PNHP created this website, and others have joined in, and it provides various ways in which you can support the actions against the spreading of privatization to traditional Medicare. So that's my pitch, and I'll be glad to answer questions or open up the discussion.
Sheldon, you were first.
Thanks. There's so much in there. Where to begin?
You should see what I left out.
Yeah. Thanks. I mean, it was great. And I have to tell you, I didn't realize how important it was for me to attend because I misunderstood what the direct contracting entities were. I thought it was just another form of Medicare Advantage capitating insurers. I didn't realize that it involves pushing risk down, to the provider groups. And one of the things that Ellen and I and others, have been focusing on, we got rid of capitated insurers in the Medicaid program. We thought we were done, and this is great. And by the way, it has been successful and it has been transparent. We've saved hundreds of millions of dollars to the taxpayers of Connecticut. But moving risk down to provider groups, which is now something being talked about in Connecticut.
Yep.
The Office of Health Strategy has been really pushing this. It's actually in some ways worse than capitating insurers, because now your doctor, the one you go that you trust, the one you go to when you've got a problem, who lays out your options, has a big fat thumb on the scale. And it may even be unconscious in terms of what they tell you, because as you explained, they directly make more money by restricting access to care. So that, the really simple examples are, two drugs, one's 10 times more expensive than the other, but has way less side effects and is more effective, and super different procedures. And one is much more effective, but, more expensive. So it's really pernicious, because at least in the old days, when we fought the capitated MCOs, the doctors would be on our side. They'd be our witnesses at the hearing, and they would testify, yeah, this person really needs it. They didn't have a conflict. They were, straightforward. It's just a particularly pernicious aspect of moving risk down to the next lower level.
Yeah, that's very, very, very good, very important. I didn't point out that the only way the patient can escape this is to change doctors, is to learn that their doctor is in this kind of plan, and change doctors. And people, particularly a lot of the seniors that are being affected by this New York City's move to Medicare Advantage. They've got these long-standing relationships with doctors, and to suddenly have your doctor in one of these capitated plans means you're stuck. Often you, of course, don't know. You get a letter in the mail from the doctor or from somebody saying that, maybe from some unknown corporation, which is the DCE, saying that your doctor has joined our plan. Welcome to our plan. Your doctor has joined. And it doesn't say that if you don't want to be in our plan, find a different doctor. Of course, the CMS's idea is eventually all doctors will be in it. You won't be able to escape the very kind of thing you're talking about.
Representative Johnson.
Thank you for this really informative presentation. It really helps me really get where the capitation is, because I was not really clear about exactly how it functioned. Because my orientation had really been in Medicare C, which was the HMO/Medicare Advantage program. And this is a different type of capitation. And
Yep.
of course, we've been very lucky to have dumped the private insurance industry for the administration of the Medicare program, Medicaid program rather. And so the combination, but on the other hand, at the same time that we have this ongoing situation with the changes in how the Medicare program is running, and it looks to me like a progressive forced capitation because the DCE that, and at the same time we have the consolidation of hospital services. So I have very limited access because the networks are being run by Hartford Health, Yale, and I guess Danbury. So we have those kinds of things coming together to really limit how we have access to healthcare here. And so I guess one of the questions that I have is, they must have a limitation on the medical loss ratio. And I'm wondering, you mentioned that there was no, real limitation on the cost, but I think at some point in time, they have to have a look at that, or it's not even considered insurance. And there's kind of definition in our statutes that goes into that somewhat. And I just wondered how that works, if you had any idea about that.
Well, the Medicare Advantage outfits, I'm trying to think if I don't know if they're covered by the requirements of the ACA in terms of the limitation on their medical loss ratio. If you look at the way the DCE plan works, their medical loss ratio can be as low as 60%. They could keep 40% of the money. It's rather extreme because they wouldn't be providing very many services, but it's allowed under the legislation.
Yeah, that's right. That's what I'd heard. And that's what I found to be quite extreme. Also, that's allowed with dental plans, but that's about the only plan in Connecticut that gets to that 60%. So,
Yeah.
So
Well, Medicare, of course, isn't covering.
Of course, I mean, I understand Medicare is federal, and a lot of the rules would be federal, and I guess the Medicare supplements are also federal. They were changed to having the supplements under the fee for service, and then there's Part C, Medicare Advantage.
Right.
But to have a 40% loss ratio seems to me to be wow. And I mean, how could they not jump up and down and scream about that when at least with the ACA, you've got a 20% to or 15%, depending on the size of the insurance company medical loss ratio. So I'm just wondering that seems to me quite extreme and terrifying, actually, if that's what they have, and especially if they are capitating as well. And then
Yeah.
the confluence of the different
Yeah.
consolidations of the networks of the hospitals and
Yeah.
provider services here. I mean, you see Harvard Health around here, they're building buildings in every town. There's
Yeah.
big buildings and
Oh, yeah. Yeah.
it's,
No, I mean, the
it's a
problem with,
combination coming together, and it's really going to squeeze out the person that needs the health care.
oh, yeah. Yeah. Well, and it's all invisible to the patient. I mean, as you say, you don't know what the incentives are that are operating on your provider when they're in this kind of a program.
So in terms of the other thing, I'm wondering if there's a way to address some of the other types of plans with wraparound services for low-income people. I mean, we have Medicare Savings in Connecticut, which has really been something that we've been able to keep and not, and I've been working really hard to make sure we don't have an acid test on that. Other states do, and I don't think that anybody understands that you don't do acid tests on seniors.
Yeah. No, that won't get around the limitations that the DCE program is imposing by being capitating everything.
Correct. Well, I thank you for that explanation. And do you have like written materials, because we will be talking about this?
Well, take a look at the slides that I sent.
Okay.
Holly will send around my slides.
Excellent. And do you have, like, the DCE is really
go to that website, protectmedicare.net.
okay.
That's where you can find anything you want to know about the DCE program.
Excellent. Well, thanks again. Appreciate it.
Sure.
Yeah, Representative Johnson, we also have a lot of that information on our website as well, which you can link directly to the PNHP website through there as well. We work very closely with PNHP Connecticut. Myself and Rana and Sivan are members of PNHP Connecticut as well, and we work very, very closely together. And Dr. Marilyn Vacher is on this call as well. So yeah, please, we all really work very closely together. Peter, you have a question. You're on mute.
No. Sorry about that. Which Peter? Was it me?
You, sir, Peter Frank.
Yes, okay.
I'm sorry.
Okay, sorry. So the Biden administration is proposing one of the largest pushes to fund private companies and privatize Medicare. Why is he doing that and going back on his campaign promise? And how do we fight back against that? And just to personalize this, I've been on straight Medicare for 20 years, and I just switched to a Medicare Advantage plan because and it's Aetna, because they're giving me $1,000 a year for dental coverage, and I think it's $180 for vision, because I've been without those coverages, for 20 years, and as a result, I have severe, dental issues, and I haven't had vision, checkups in so long. But the reason I switched was specifically to get that, and now I have to go for an MRI, or actually a couple of MRIs, and I just got a letter or a couple of letters in the mail saying that my pre-authorization for the MRIs had been approved, and the last time I went for MRIs, I never had that experience before, so I was very confused by that. And when I saw your figures in the presentation, that the overhead for Aetna, and I know that the overhead is so much more expensive with private companies, that the overhead for Aetna is 17.4%, as opposed to Medicare, which is 4%. Why am I now giving my Medicare premium, almost, I want to say 18%, going to Aetna, as opposed to CMS, which is 4%,
Mhm.
and it doesn't make sense that Medicare, which is a great program, it's been run great by CMS, that we're now giving it back to the insurance companies to stay in the private insurance companies. If we're going to do Medicare for all, why are we going to do it if we're just going to give the money back to the insurance companies and make Medicare not as um what's the word I'm looking for? I'm sorry. Um competitive and
Comprehensive and
uh,
affordable.
no, not as oh, I'm sorry, what's the word? It's not as managed. It's not, but not managed isn't the right word, but
Efficient, maybe?
efficient, right? Efficient as it has been in the past. I mean, we're basically taking the efficiency out of Medicare by bringing the private insurance companies back in. So, I
Absolutely.
mean, why is the Biden administration doing this? The largest increase to private insurance companies in Medicare's history.
Um, I'm not sure whether you're talking about the increase in the Part B premium this year, which was a Biden administration action, or direct contracting, which actually began under Trump. And what our
There was
complaint is that the Biden administration is continuing it. Um,
there
it
was a news article I read that said that he's increasing um oh
I think it's the Part B premium you're talking about.
no, it's not the Part B premium. It's I don't know if it was when I registered for the event. I think I submitted the article, but it's increasing contributions to the private contractors. So to the Medicare Advantage program.
Um, yeah,
Um,
that's right. Yeah, that's inflation adjustment. Yeah, yeah. That they're that's yeah, they got like an 8% increase in that's in the general capitation payment that they receive. Um, look, Washington is dominated by business. As somebody is reputed to have said, the business of America is business, and and you're a poster person here for the Congress having allowed Medicare Advantage plans to provide dental and vision coverage, and not allowing Medicare to provide it. It was included in the Build Back Better bill that died in the Senate. It was the one. I mean, there was some limited extension of coverage for those in that legislation, but at the moment, you're absolutely right. The only way you could get coverage under Medicare was to go to a Medicare Advantage plan, and you got these authorizations. I take it they approved your MRIs. Um, um, the doctor didn't have to check with Medicare when you were in straight Medicare, because there's no prior. It doesn't have anybody sitting on any phones waiting to get calls from your doctor.
yeah, it
Thank
was
you
just
for your
crazy.
comments. It was very helpful to interesting to get a case study in the catastrophe that is happening to us.
Okay, go ahead, Sharon.
Hi, I'm very new to this, except I just retired as a nurse practitioner from Yale University and worked in the inner city in New Haven, actually on a medical mobile van. Most of my clients had straight Medicaid or Medicare. And I do remember sitting in this very large, stuffy auditorium in Yale and being presented with this managed care and how we are getting rid of fee for service because it was so expensive. And their data was remarkable this was a full physician house and convincing physicians that this was the way to go. We need to manage this, that fee for service was not bringing in enough money to pay physicians and practitioners of any kind enough. So I also see that in a busy practice, my ability to understand and give comment when I was working was almost nil. I just had to follow the medical directors and the administrators of medical practice that I was in determining this. So the providers, and then I started getting hit with this, well, your Medicaid Advantage program and you don't have dental and your teeth are falling out. Well, of course you're not going to eat and you're not going to be able to work and see because you don't have dental and vision. Hello, that's like so common sense that you can't fight it from the providers. Administrators just say, this is the way it's going to be. This is how you're going to code now. We're not going back to that. And I don't know where they get their data, but their data said that they made more money that way with these Medicaid advantages and getting rid of fee for service. And you're just going to get it, not count how many times people walk in the door. You're just going to get paid a lump sum for having this patient. And my patients weren't cheap. I was HIV, hepatitis, infectious disease, drug abuse. And that then you had to fight to get the drugs and you had to fight for private authorizations. And I had people that were sick, needed to get into a great example is hepatitis care for cure, but I couldn't get in. They couldn't get in because they had to wait for the insurance. And by that, if I tell a poor person they got to wait, that's not right. So the provider, I got so frustrated, was another reason I got out of that system and took the retirement, is because I couldn't make the change I needed to make for my patient. And I didn't have the time to go and make the change to Medicare. It's a horrible position to be in as a provider.
Yeah.
And if I saw one more prior authorization for anything, I thought I was going to a few times I did scream at the prior authorization people. It's like Connecticut. I had to retire. They knew my name. So.
Well, that's why, even some hospitals that can afford it afford to not have the patients stay out of Medicare Advantage plans.
Right. And so, and I'm going through this now as a retiree on Medicare, and I'm saying, what is this horse shit? Why am I paying this Advantage card? Because hello, I wear glasses. How else am I going to afford what a pair of glasses costs? And you still have to pay over and above. That Advantage plan doesn't really take care of all the costs for people in it. But as providers, we are just swept downstream in the flood. And I don't know how providers, we were saying, well, that makes sense. We don't have to worry about fee for service. We don't have to worry about how many times the person comes in, be playing the game of, oh, I can get you to come in 16 times so I make more money. That was the old plan. Now the new plan was supposed to be, oh no, I'm just going to take care of you, which is crap, because that's when they get the ACOs, or I'm sorry, terminology is new to me, but these other private groups coming in to do this. The single payer is the only way to go. It's like stupid. And we spend so much of our medical brain doing bullshit that has nothing to do with care and takes us away from the patient. It's horrible. So I don't have the knowledge and the words to talk to the insurance people to say, or a politician, although I have given voice at the Senate in Connecticut, but on different issues. But I have to do that from a practitioner's point of view, not from knowing anything about these complex insurance systems that are just hurting our patients again.
If I can say to that, Sharon, the only thing that you said that I disagree with is that you can't speak to any of this because you have just spoken about it to all of us very convincingly and very succinctly about your experience and how, as a provider, it's incredibly frustrating for you, and as a Medicare patient, how it's incredibly frustrating for you. So you have that power to speak to every single one of that, just as everybody has their own, is expert in their own experience. So I would really, want for you to feel empowered to advocate on behalf of yourself, first of all, but also on behalf of providers, because nobody needs to know all of this language. It's ridiculous. They make it so that nobody understands it, and then they intimidate, and that's the intimidation to try to keep people away from trying to change it. But when we say enough is enough, I can't even see my patients, as Donna was saying in the chat, how it's so much easier for her experience with claims in Connecticut than it is, just an hour away in New York. That's very powerful for people on the street to hear, because a lot of people don't know or think that physicians are as frustrated with the system as patients are. So I think you have very powerful information at your hands.
Yeah,
Thank you.
I hope you're in PNHP, and if not, you should
Oh,
be.
yeah.
No, I'm not in there. This is my first meeting.
Oh, welcome. Well, we will put you in touch. Marilyn Vacher is here. She's the, are you the president chapter of the president?
I think I'm like the person who sends out the emails and the agenda.
Well, please. give me
Very
access.
powerful, yes. So we should put you guys in touch, and because it's a really wonderful group of fellow providers and non-providers such as myself and Holly and Rana, and we all were involved in this anti-DCE push. It was a small group of us here in Connecticut, but nationwide, we at least got them scared enough to change the name to ACO Reach. That's something, so we just have to keep that up. And more stories and testimony like yours is what makes it happen.
And the amount of money that's going to administration and paying these Medicaid Advantage insurance. I said to the guy when I was talking to him, I said, how do you make your money? And he did not look like a shabby office, like my office. They are making a lot of money by the insurance companies to pull people in with scare tactics and the small copay. We've heard those before. It's like car salesmen,
Or
no
no
car
knowledge.
salesman.
No knowledge at all. They have no choice. They automatically move them over, and most, you get another thing in the mail from Medicare. Just throw it in the garbage or send it for later. And
Right.
don't understand what it is. There's no one to call, and the only way to get out of it, right, is to change your doctor, and that's like the worst choice. People don't want to do that.
I also have a comparative analysis in my home. My husband is just switched over because of this garbage to full VA benefits. And that has been very interesting. And there is a copay for very small copays. And he just finished some extensive medical treatment, and it was a much better system to work with. And the providers were not going crazy. Like I was going crazy, and the people I worked with going crazy to get my numbers up. And I just say, I don't work by numbers. I work by people. But I was in so it was a good time for me to leave. But that is an interesting system. And I don't know where that is in comparison to, why does the government fund that system so differently?
That's a National Health Service. That's what that is.
Right. That is right. And it's run so efficiently. And the docs don't have to worry about anything. And we see a lot, I've talked to a lot of them, and it's a very simple system to get into. And they just focus on the patient. And they're not bringing in authorization forms and find this, get me a social worker. Oh, you can't leave because the social worker's not here. The social worker's went crazy. And you have to sign these forms to get a prior authorization and get back to me. No, he doesn't do any of that. And that's a model that the federal government has that seems to be working a lot better than it used to. And we have a lot of providers and nurses going to that system because it is one less big headache. But I don't know how you can even compare the two. And I don't think perhaps it's can be, but the federal government manages it pretty well, I think.
I would say, actually, there's two examples of a functioning national health program, that and the Indian Health Service.
Yes, yes. Right.
Yeah.
And I've never been in either service as a provider or as receiving care or working in that at all. But it is very, very, as a provider, I talk to the providers because my husband's going through this, and people that I almost did it, but I couldn't get, I don't know why I didn't go, but I had thought about going, and I did interview at the VA. Well, plus my focus was not really the veteran. It was a very, very, for the provider, it was a lot less stress because of the insurance nonsense and meeting quotas. Maybe they have quotas now. Maybe it's because I don't know a lot about it, but they're saying, we're here to take care of you. And oh, you need dressings? Oh yeah, here, let me go to the closet, get them to you. Oh, what kind of med? Oh yeah, we'll get that to you, right? Delivered to my door overnight. Nobody asked me what his insurance or how long he served, where he was, or anything. It's quite amazing that then the government can do that fairly efficiently. I don't know what their profit margin is on it, but we don't have to get involved in the insurance.
No profit.
No profit. That's right. Why you can't do it? Follow the money. My husband's the finance guy. He goes, just follow the money. Just follow the money. So, but you can still see the false story that is given to providers is that they're going to make more money on this, whatever it is, DCE or the ACO or whatever. They're going to make more money, and they're not going to be given raises and given their promotions on how many patients they see, which is a lie because they all do that. See, I think it's and when I was sitting in this room, I'm going, oh, it sounds good. So I don't have to worry about how many patients I have to see, every month. You go to the table and you're saying, so you saw this many around the table. You got to get your quotas up. You got to do this. I mean, I said, you don't do what I do. You're not out in the streets. People don't walk into my office. So very, very different. It's like they're making it hard for providers to really understand what's going on for the patient and how much it's costing the patient. Now, as I'm a provider that's on Medicare, I see the veils lifted a bit. But when you're so busy, the administrators take care of that. In medical school.
Sharon, I honestly don't think they just don't care. It's not that they don't want to they just don't care to. Not the providers, because the providers do care about patients,
Yeah,
but
yeah.
the insurance industry doesn't care. That's the whole point. That's why we do this,
Yes.
because we know they don't care. All they care about is the bottom line. And
Right.
this is why we're doing this. Well, this is why we're here. The insurance lobby actually spent several $1,000,000 to try to stop just the public option in the state of Connecticut. It was ridiculous. So, I mean, this is the whole point is they don't care and they need to get out of our lives.
Yes.
You know, like Sivan has said in the chat, our lives, our health should not be bought and sold on the stock market. And that's why we're here.
That's
And
right.
this is why the movement is going, because this should not happen.
Right.
And, you know, so that's the whole point. You know, they don't care. They don't want you to understand, because the more you understand, the more you realize that it's a dog and pony show for them. It has nothing to do with helping people get healthier and to stay healthier. It has nothing to do with that. It has just to do with their profits, period, end of discussion.
Yeah, it's like Big Pharma when they walked in my office and they would say, here's your oxycodone you can prescribe. You know, this is why you do it. This is the longer acting one. And look what happened to most people. I kept saying, guys, you're in the wrong office.
Yeah.
But
Yeah.
Big Pharma was chasing us all the time. And not in Gale so much, they threw them out, but in other practices.
Yep.
That's how we got into the mess.
Mhm.
That mess. This is
Yeah.
the other mess. Yeah. Thank you very
Well,
much. I've
You're
gone
very
on.
welcome. No, that's fine. We all feel that way. That's why we're all here. We're all together. We're fighting this fight together, and we're glad you're here.
Thank
So,
you.
Thank you. Does anyone else have any other questions for Professor Rodberg?
Just a final comment that I think that the problem, the overall really, really big problem is the Kool-Aid problem. And what's happened is this perverse thing where we've accepted that having capitated insurers, where they have a financial incentive to deny care, that makes sense. And we're unwilling to shake it. We're unwilling to get rid of it. And because we're unwilling to get rid of it, we have all the waste, inefficiency, and you know, high cost and drama associated with it. And rather than recognizing, yeah, the problem, the root cause is that structure doesn't work, we then say, okay, then what we need to do is address costs by putting financial risk down one level, which is on providers, and replicate the same thing all over again. So that is really fundamentally the problem. And people at CMS, you know, that quote that Len had was horrible about by 2020, by 2030, they had just all bought into this because they're unwilling to be able to see that the fundamental structure is wrong. So don't replicate it and put it at a lower level where you then have the problems I mentioned that, you know, docs now can't even be honest brokers. I don't know what the answer is. I mean, I guess we're all sort of looking for that. We're all looking to Bernie and whoever, but you know, it's really hard. How do we deal with the fact that there's an unwillingness to recognize what is staring at us? And we know it's right because most of the rest of the world has done it at 10% of GNP instead of 18 or 19% of GNP.
Yep.
Thank you, Len. It was great.
Thank you.
Thank you.
It's been a pleasure talking to all of you.
Thank you
Okay.
so very much. Thank you. And
If you have questions or comments, send them to me or to Holly.
yeah, we'll forward everything. So thank you again so very much, everyone, for
Sure.
being here, Professor Rodberg, everyone for your advocacy work. Thank you all so much. Sivan, did you want to say something?
Oh,
or are you
yeah.
good?
Yes, just to say tomorrow night, we're going to have our monthly activist meeting at 6 o'clock. Tomorrow.
7 o'clock is the activist.
7 p.m. Excuse me, 7 p.m. So I will put that in the chat if you want to register for that. That is where we once a month just all get together to talk about the actions that we need to take. It's all great to discuss this in theory, but ain't nothing going to change if we're not out on the street informing the people and making this all a reality. So we'll be talking about our summer fundraising efforts, our town resolution efforts. We've got some great news on Hamden, and our education efforts as well. Holly is working on a great sort of COVID information program as it relates to healthcare costs. So I'll drop that in the chat. And then also we, we're always accepting donations. We have swag now. So I'll put that in the chat if you want to show your Medicare for All pride. We've got cool tote bags and mugs and bumper stickers and buttons. So please consider donating to us or consider monthly recurring donations. Those are really super helpful. So hopefully we'll see everyone tomorrow night at 7, and I'll get that link for registering for that now.
Yeah, I'm not good with that kind of stuff. I need Sivan, I need Rana for that. I'm just learning all of this cool stuff.
Here.
Looks good. Okay. So long, folks.
Thank you, Professor
Thanks,
Rodberg. Thank
Mildred.
you so much. Have a
Yeah.
wonderful evening.
Sure.
Thanks.
Well, good night, everyone. Did you see how light okay, recording off now, right?
Super light, super light.
I